Welcome to this session of PMAC 2021, which is on forms of discrimination, social exclusion, with specific focus on inequitable impact of COVID-19 pandemic. So I'm going to give a brief overview or background to the session, whereafter a brief introduction to each of the panelists, and we'll move through the sessions. We've got times for questions and answers. What we would ask is that all participants please write your questions into the chat box, and there will be people who will be collating those questions into grouping them and then directing them either in general to the panelists or to specific panelists. If your question is directed towards a specific panelist, please identify which panelist that is. So just a little bit of background is that sort of discrimination and violence against particular groups of people is nothing new. It's something that's been with us throughout history. But what has happened is that it's been exacerbated more recently during the COVID epidemic. So, for example, in South Africa, where I'm from, the lockdown saw huge increase in gender-based violence and violence against children. Hotlines had to be opened where children could call in to report it, but there was a problem because you were locked into a house with the people who were perpetrating the violence. So today we've got a number of panelists who are going to explore, describe the forms of discrimination and social exclusion against particular population groups, identify the underlying political, economic, and social drivers of these forms of discrimination, and discuss the role of COVID-19 in exacerbating these forms of discrimination and the socio-economic determinants that shape the COVID-19 response, leading to these inequities. So an overview of who will be on this panel and where they're from. We've got Pat Anderson, who's from Australia, Carlos van der Laat, who's originally from Costa Rica but living in Switzerland, Dr. Aziz Rali, who's from Morocco, Dr. Sama Jabor from Lebanon, Anna Vrakar from Croatia will be moderating the session and will be compiling the questions together with Hani Sirag, who also put together this, coordinated the session, and Gagea will also be assisting with those questions. First up, we've got, and I'm Bridget Lloyd. I'm from People's Health Movement, Global and South Africa on a volunteer basis at the moment. So first up, we've got Ms. Pat Anderson. Pat is an Al-Yawari woman known nationally and internationally as a powerful advocate for the health of Australian First People. She is chairperson of the Lawija Institute and has extensive experience in Aboriginal health, including community development, policy formation, and research ethics. She's chaired and served on many committees working on Aboriginal health in Australia and is very well published. She's received many awards in recognition of her work on health and human rights of Aboriginal people. In 2013, Ms. Anderson received an honorary doctorate from Flinders University. So Pat's going to take us through experiences within Australia. Over to you.
Good evening, ladies and gentlemen, colleagues and friends. I'm speaking to you from the country of the Ngunnawal and Ngambri peoples, traditional owners and custodians of the land upon which the city of Canberra now sits. I'm honoured to be able to speak to you this evening. I want to outline how we, the Aboriginal and Torres Strait Islander nations of Australia, have responded to COVID-19 pandemic, the latest threat that colonisation has brought upon us. I want to sketch the role introduced diseases have played in our history. And I want to share with you how our First Nations organisations have kept our communities remarkably safe from the coronavirus, which has caused such havoc around the world. But we have to put this success in the overall context of colonisation. Our First Nations of Australia have been here for at least 65,000 years, according to the scientists, but we believe from the beginning of time. Whereas non-Aboriginal people have occupied Australia for a comparatively tiny amount of time, a little over 200 years. The relationship between First Nations and those who came after us has been diverse, difficult, and complex, and remains so. But in every part of Australia, we have suffered violence and dispossession, exploitation and marginalisation, impoverishment and theft, including the theft of land, of cultures, and even of children from our families. These histories have marked us deeply. However, our peoples have always resisted. In the early years of colonisation, this was through armed struggle to defend our lands. We have never relinquished sovereignty over those lands. After the early years of the invasion, generations of us and of activists have led a political struggle to have our rights recognised. Fundamental to this struggle has been our right to self-determination, which we maintain and defend to this day. One of the contemporary expressions of self-determination is a network of Aboriginal community-controlled health services which provide high-quality, comprehensive primary health care to our communities under the direction and control of those communities. These health services have been instrumental in keeping our communities safe during the coronavirus pandemic. I'll say a little more about them in a little bit, but before I do, I also want to mention the Uluru Statement from the Heart, a powerful declaration from delegates of our nations who met in the desert heart of this nation in 2017. This statement was given to the Australian people, and it was a call for 3 reforms. First, a national body of our peoples to be enshrined in the Constitution to speak directly to our Parliament. Second, treaties or agreement making to reset the relationship between us and non-Aboriginal peoples of Australia. Third, a process of truth-telling to underpin this relationship between our peoples and the nation state. Although the demand of those delegates at Uluru continued to be rejected by the Australian government, the Uluru Statement still stands as our unified demand for recognition and justice. Now, let me turn now more specifically to the COVID pandemic and its place in our colonial history. The first thing to say is that disease has been part and parcel of our experience of colonisation. In the early days of colonisation, which came at different times in different parts of our vast land, introduced diseases to which we have no immunity, devastated many of our communities. These diseases severely undermined our capacity to resist the invasion of our lands. There were also deliberate attempts at genocide by the colonists who weaponised disease by deliberately infecting our communities, for example, by giving people blankets infected with smallpox and other deadly pathogens. Since those times of open conflict, other more recent pandemics have also disproportionately affected our peoples. For example, during the 1919 influenza pandemic, mortality rates amongst our peoples in parts of remote Australia were almost the highest in the world. As many as 1 in 4 people died in those places. Even more recently, the 2009 H1N1 influenza pandemic saw much higher rates of hospitalisation and mortality for our people compared to non-Indigenous Australia, reflecting the poverty, dispossession and exclusion which have been part of the result of colonisation. This history is still very much part of our experience. It explains, I think, why our communities were so concerned, realising very early the potential catastrophic impact of COVID-19 would have upon us. As soon as we heard about the spread of the coronavirus early this year, we knew that overcrowded housing, poverty, and high rates of chronic disease would mean that COVID-19 would be devastating if it got into our communities. Tragically, we have seen this pattern in other First Nations around the world, Black and low-income families and marginalised communities elsewhere. and we're going to hear about that tonight in this panel. Of particular concern to our people was the need to protect our elders. Our elders are the holders of our cultural knowledge, history and languages. As Pat Turner, the leader of our Aboriginal Health Services sector, said back in March 2020, if we lost them, it would be like burning down libraries. As the pandemic swept the world, the danger to our people was imminent and very real. But here we are, over 6 months later, and cross fingers, so far, our communities have been largely safe for the moment. As of July this year, we have seen only 60 First Nations cases of COVID-19 nationwide. This is less than 1% of cases, with our people making up 3% of the Australian population. Very few of these cases needed hospital treatment, and there have been no deaths. This is an extraordinary success, but one which must be cherished and kept working hard to maintain. So why has Aboriginal Australia stayed safe so far? I will identify 3 reasons. First, our communities demanded strong, decisive action. The experience of previous pandemics meant that our mob were advocating for restriction on movement and other public health messages very early, before it was even on the agenda for the mainstream. We knew this pandemic story, and we knew that if we didn't act, it would end very badly for us, as our history has told us. Our people quickly took their own action to prevent transmission into their communities. In some places, even our children would stand beside the road with signs urging travellers from other parts of Australia not to stop in their community to reduce the risk of transmission of the disease. And there are 2 slides which are up on the screen just to illustrate that. The first lesson I would draw stems from the role of the Aboriginal Community Controlled Health Services.
3 minutes left.
3. They developed a model of responding to COVID-19 that was based on high quality public health knowledge, informed and led by community knowledge and authority. We have lived here on this continent for a very long time, and we have learned how to live sustainably and safely in this beautiful but ancient and now fragile land. We have developed an extraordinary depth of knowledge about this place. Our communities are prepared to offer that knowledge to help all Australians, whether it is how to prevent the spread of COVID-19 or using our traditional land management practices to manage bushfires and mitigate the threat of the climate crisis. But to do this, mainstream Australia has to recognise the realities of our shared history and the experience of our peoples of colonisation, exclusion, racism and intergenerational trauma. That is what brings me back finally to the Uluru Statement from the Heart and those hundreds of delegates gathered around Australia in 2017 to demand voice treaty truth. This is our gift to the nation, the basis for genuine peacemaking and the foundation of a shared and healthy future. Thank you.
Thank you very much, Pat, and especially for sticking very promptly to time. We're going to move straight on to the next speaker, which is Carlos van der Laart. Carlos works for the International Organization for Migration. He's the Migrants Health Assistance Program Coordinator. Carlos, over to you.
Yes, hello. Thank you very, very much. It is for me a big honor and pleasure to be part of this panel. I'm trying to share the screen here. So it is very important also to discuss about the unprecedented threat from COVID-19, not just for our own health, but also impacting strongly on the health systems, on our jobs, on our families, spreading human suffering, affecting global economy. So to start, we need to remember that for migrant, refugee, and other displaced populations, their situation was very challenging before COVID. The objective of this presentation is basically to set base in terms of additional challenging current context that migrants face now in the COVID-19 era, recognizing that special actions need to be designed and implemented to guarantee inclusion. So basically everything is about inclusion. What we are now learning from this experience is that we'll get through this crisis, yes, but only if we act together in solidarity. This virus is a threat to all humanity, regardless of nationality, ethnicity, or faith. Basically, the world is as strong as the weakest health system. So, as we all know, the virus appeared more or less 10 months ago. Initially, we thought that it would be just a challenging time for the health sector, affecting mainly people with pre-existing conditions. We thought that by strengthening the health systems, we would be ready to face it, and that those countries with strong health systems were going to beat the virus very easily. But no, we began to hear other voices, sometimes too many voices. We saw that the issue was also highly political, revealing in some countries big gaps, and revealing also missing or weak public health policies towards certain populations. We also realized the importance of human behavior and personal perception to health. People totally denying the existence of the virus, shouting for freedom or avoiding quarantine or avoiding the use of the mask. The situation got more and more complicated. And then we also understood the link of the disease with socioeconomical condition, with bad sanitation, with risky home conditions. And then all the hidden truth came to the surface, all the systemic inequities, structural barriers based on race and ethnicity. All the inequities were now visible, even in societies that were considered as highly advanced. This was now visible, the big gaps. And finally, the virus revealed also the enormous weight of human mobility, for good and for bad. It made us think about borders, which were basically able to delay the arrival of the virus, but were not able to avoid the entry of the virus in any place. So we realized the enormous cost of closing borders and the enormous human cost also associated with confinement. Very, very challenging situation, but also a lot of lessons to learn. We're also seeing a reduction in terms of global, regional, local mobility due to fear and to travel restrictions. There is also lack of confidence in the public health measures and stricter, probably, health requirements for travel. And with those more complex requirements to travel, we'll probably see also an increase in terms of irregular migration, and with it, more health vulnerabilities. So now with COVID, we are learning many things, I would say. And now it's not necessarily about leaving no one behind. We have learned that it is basically that if someone is left behind, no one will move forward. So it's all or none of us. We need to move as a group, as a society. So the panorama is quite challenging. Here I have some pictures of the current scenario where it's clear that it is much more than just a health sanitary crisis. With or without COVID, people continue to flee violence. Conflicts are still there. They are still there, but protection is suspended because of COVID. We can see how fear and not counting with information is also creating vulnerability. So it's better not to be tested to avoid more discrimination. So I hide from the authorities, not to be tested to avoid more discrimination. The fear of being locked in not secure places also that increases. The anti-migrants violence, not allowing food or medical care to be provided within those refugee camps or with those places where migrants or refugees live. The fear from stigma, with only one big outcome, that is basically higher exposure to the virus. And then the fear of living in places without sanitary conditions, without water, with no possible distancing. So just imagine for them in that picture, what it means when we say keep your distance, when we say wash your hands, when we say use hell, in alcohol, hell, use a mask, etc. Those measures are very difficult for these populations. Some and many other challenges. The pandemic exacerbates existing vulnerabilities. That is important to highlight. There are existing vulnerabilities that now are exacerbated and impacts people on the move, basically in what we're saying 4 interlocking crises. So there's one, the health crisis, the more obvious, I would say, mainly affecting migrant population. Why? Well, because they are not assuming a passive role within the crisis. They are the heroes, cleaning the streets. They are delivering the food. They are guaranteeing stock at the supermarkets. They are caring as physicians, as nurses, caring for all people in houses, homes, and in hospitals, etc. But that active role also of the migrant population also means more exposure to the virus. The health crisis also in terms of continuation of services. More than 71% of the countries reported disruption in routine immunization, as an example. 66% reported disruption of health services for non-communicable diseases, as education, as diabetes, as cancer, etc. We have also the socio-economic crisis with unemployment for migrant workers, which led also to regular migration status and terrible impact of communities of origin where people depend on remittances for food, medicine, education. We have also the protection crisis with restrictions that also impede humanitarian workers to provide their life-saving services. Closed borders, basically states closed all entries for people who are seeking protection. And those who are already under some sort of protection or a refugee camp or recognized as asylum seekers are now encountering also fear, hunger, stigma, discrimination, and big uncertainty also regarding their situation. Finally, the perception crisis that I said, I don't know, I'm here. When we start thinking only about our security, when caring about others seems to be not as important, and when governments start applying restrictive sanitary measures and based on xenophobia and persistent inequities. So we are now learning a lot from this experience, and that the thing that we know is that we are going to move forward. We're going to go through this crisis, yes, but only if we act together in solidarity. I want to insist that the world is as strong as the weakest health service. So we need to ensure the mobility is taken into account in public health messaging to ensure that information is communicated to migrants and mobile populations. As you can see here, legal status, discrimination, language barriers, all those limit the access to preventive material, to information. Public health announcements may not reach them also, or they are not included within the national strategy. They could also, it could also be difficult for them to find them because of their mobility. So we need to work to advocate for the inclusion and non-discriminatory access of migrants, of refugees to the public health services, translating of and disseminating of public health information through efficient channels, also including migrant populations within the national support packages, adjusting to community perceptions, beliefs, practice. We need to diversify communication if we want really to succeed with it. So from IOM, we reiterate the need for migrant inclusive approaches in the overall COVID-19 response. It is true that we need we cannot win this unless we really work directly and include these migrant populations. So finally, I leave it here, but to remember that public health only works when everyone is included. So thank you very much.
Thanks very much, Carlos. Sorry, I had to cut you short. That was really interesting. Next, we've got Dr. Aziz Rali, who's from Morocco, and he is the president of the Moroccan Association for Human Rights, the coordinator of the Coalition for Health in Morocco, and also serves as the vice coordinator of the World Social Forum for Health and Social Protection, and a member of the International Council on the World Social Forum. He's also a member of the Coordinating Bureau of the Arab NGO Network for Development. He's speaking about human rights in the era of COVID-19 pandemic, and particularly looking at the case of prisoners, including political prisoners. Thanks, Aziz.
Thank you, Brigitte.
Aziz is presenting in Arabic, and Hani Sirag will give a summary after Aziz has spoken.
Thank you, Brigitte, and thank you, Hani, for the resume my intervention. It will be in Arabic. My presentation will speak about the situation. مداخلتي ستكون حول الوضع الفقر في منطقة شمال إفريقيا والشرق الأوسط. Il y a un problème d'internet au Maroc.
I think Aziz might have dropped off. I'm just checking if Aziz is on, because he said there was...
Excuse me for... أعتذر عن هذا الخطأ لأن كان مشكل في الإنترنت هون في المغرب. ففيما يتعلق بالعرض سأحاول أن أذهب بسرعة. فكان الشعار الكبير الذي رفع أثناء جائحة كورونا هي الأرباح قبل الأرواح. فعند ملاحظتنا لمشكلة الفقر في المنطقة ككل، لاحظنا على أن معدلات الفقر في المنطقة على عكس ما يقال أو على عكس ما يتم الحديث عنه، فإن الفقر في المنطقة منتشر بشكل كبير جدا، وذلك من خلال مجموعة من المؤشرات. أولها على أن في المنطقة على عكس ما يقال أنها منطقة غنية وغنية جدا، فالفقر انتشر بشكل كبير جدا. فإذا أخذنا مثلا المغرب كمثال، وبعد ذلك أتحدث عن الدول الأخرى، فالمغرب كبلد عدد الذين 40% من ساكنة المغرب لا تستفيد من أي حماية اجتماعية. كذلك أن هناك أكثر من 26% من الساكنة هي التي تستطيع أن توفر الدواء. هناك 60% من ساكنة النشيطة في المغرب تصل إلى سن التقاعد دون أي تقاعد. كذلك هناك مشكلة على الصعيد الدولي، من خلال عدد الفقراء الذي ازداد، فمعدل جيني في المنطقة في منطقة شمال إفريقيا والشرق الأوسط كان في حوالي 0.354، لكن مع أزمة كوفيد انتقل إلى 0.546. ولما نتحدث على مؤشر جيني، فهو الذي يتحدث أو الذي يشير إلينا إلى مدى التفاوتات. كذلك في الصورة الآن نلاحظ على أن نسبة النمو في منطقة شمال إفريقيا والشرق الأوسط كذلك ستعرف انخفاضا كبيرا، إذ أن هناك في بعض السيناريوهات تتحدث على أن الانخفاضات ستكون ما بين -10 وناقص 12%. كذلك فيما يتعلق بالآثار الجائحة هناك ارتفاع كذلك فيما يتعلق بعدد الفقراء في المنطقة. فمثلا في المغرب كان هناك محاولة أو كان هناك حديث على أن نسبة الفقر ستنخفض، لكن لاحظنا على أن مع جائحة كورونا عدد الفقراء في المغرب وصل إلى 25 مليون شخص في حاجة إلى دعم ليستطيع أن يعيش. ولما نتحدث على 25 مليون فتقريبا ثلثي ساكنة المغرب وجدت نفسها أنها غير قادرة على توفير إمكانيات العيش اللائق. كذلك فيما يتعلق بالوضعية الصحية في المغرب وهي من آثار جائحة كورونا فكانت هناك الفروقات واسعة جدا، إذ أن في القطاع الخاص الآن التداوي في المغرب من ضد وباء كورونا يتطلب حوالي 10,000 دولار، في حين على أن التكلفة بالنسبة للفقراء أو الأدوية التي توزعها الدولة بالمجان ثمنها لا يتجاوز 25 دولار. وهنا يتضح لنا الفرق بين إمكانية التداوي بالنسبة للطبقات الغنية مقارنة مع الطبقات الفقيرة في المغرب. كذلك على أن الوضعية الصحية أو وضعية الفروقات في المغرب هناك كذلك توزع كبير بين المجالات. فمثلا إذا أخذنا منطقة الدار البيضاء وطنجة والقنيطرة باعتبارها المناطق الأكثر صناعية فالوضع فيها على الأقل كان متحكم فيه، في حين على أن الهوامش أو المناطق الريفية كان الوضع صعب جدا وهناك كانت ارتفاع كبير لحالات الوفاة كورونا، والفرق يصل إلى ما بين من 1 إلى 7. إذا كان هناك وفاة واحدة في المدينة ففي القرى هناك 7 وفيات. وهذا الوضع ينطبق كذلك على جل دول المنطقة سواء الجزائر وتونس أو مصر، فتقريبا نفس الوضع أن هناك تفاوت كبير في التعاطي مع هذا المرض، وهذا ناتج للتفاوتات الاجتماعية التي تعرفها المنطقة خاصة بعد تتبع سياسة التقشف وكذلك بعد تتبع الهيمنة النيوليبرالية على المنطقة، إذ أن تبعية المنطقة لأوروبا أو لأمريكا جعلت أن اقتصاداتها مندمجة بشكل كبير جدا وأصبحت غير قادرة أن تطور نفسها أو تتقدم. فمثلا في الصورة التي تظهر الآن يتضح لنا توقعات لانخفاض في المنطقة خاصة في منطقة الشرق الأوسط أو الدول المعتمدة على البترول. هذا الانخفاض قد يصل إلى ما بين -41.27 إلى -41.64. كذلك فيما يتعلق بازدياد عدد الفقراء في منطقة شمال إفريقيا والشرق الأوسط، إذ أن عدد الفقراء كان قبل وباء كورونا 93.1 مليون، في حين أن التوقعات أن بعد كورونا وهذا إذا لم تمتد إلى ما بعد سنة 2021 سيصل إلى 101.4 مليون فقير. كذلك أن انتشار كورونا أدى إلى خسارات كبيرة في المنطقة. فيما يتعلق الاقتصاديون يتوقعون أن خسارة المنطقة أي شمال إفريقيا والشرق الأوسط قد تصل إلى 42 مليار دولار. على 42 مليار دولار، فهذا رقم كبير جدا. يعني ممكن تذهب لآخر سلايد حتى نختم. هنا كذلك تظهر لنا في المنطقة مؤشر التنمية حسب الجنس. ففي المنطقة هنا الخسارات التي تقع مثلا فيما يتعلق بدولة مثل مصر. ممكن تذهب لآخر سلايد هاني.
Last slide, please.
Last slide. No. Yes. في هذا السلايد يتضح لنا الوضعية الاقتصادية في المغرب، إذ أن متوسط معاش المواطنين الذين يصلون إلى التقاعد لا يتجاوز 190 دولار في الشهر. ف190 دولار في الشهر في دولة مثل المغرب هو راتب ضعيف جدا، والفرق كبير كذلك بين الذين يشتغلون في القطاع الخاص 190 دولار، في حين أن الذين يشتغلون في القطاع العام أو اللي يشتغلون مع الدولة فالمعدل هو 680 كأقصى 680 دولار، في حين على أن الذين دون الحديث عن الذين يشتغلون في القطاع الغير المهيكل. فالقطاع الغير المهيكل هناك يمثل حوالي 52% من الاقتصاد الوطني، و52% لا يتمتعون بأي حماية اجتماعية، وكذلك أثناء جائحة كورونا وجدوا مباشرة أمام الفقر فلم يستطيعوا أن يسدوا حاجيتهم. شكرا.
Thanks, Aziz. Hani Sirag, who will now do a summary taking approximately 7 minutes, but he will summarize what has been said by Aziz. And Hani is the ex-global coordinator some years back of PHM, and he's now working at Texas University. Over to you, Hani.
Thank you very much. Just to summarize what Aziz said, during the time of the COVID-19 pandemic, the poor became poorer and rich became richer. This statement in the beginning has been controversial. However, now it's very well proven by numbers and shown very clearly by statistics of the World Bank. Extreme poverty affect more than 115 million in the world. The spread of the poverty was not equal in different places. In the Arab world, we see in a very clear way that the impact of COVID-19 is disproportionately affect people, especially those who are working in informal employment, those who are living in rural areas, women, and also those who are working for public sector. And this is in Morocco and in other Arab countries as well. The economic impact of COVID-19, starting with the preventive measures adopted by different countries. These measures led to a decline in economic activities. And again, the decline in economic activities did not affect people equally. It affected people from informal sector more than others. Also, it affected it led to severe decline in transfers, especially for those who are working outside countries and send remnants to people in the Arab world. It led to inflation and compromised health and educational services. 81% of workforce were affected by the lockdown. And also, Aziz mentioned, related the impact of COVID-19 to the realization of SDGs. And in his presentation, there was a link between the second SDG, which is eliminating hunger, while during the COVID-19 pandemic, we witnessed a 12% reduction in the food production. And he related most of the negative impacts of COVID-19 to the economic policies adopted by in the Arab world by governments, and most of it is just following the neoliberal policies and structural reform in different fields, especially health and education. I hope I made justice to Aziz's presentation, and we will work on the presentation to make it available in both Arabic and English language after the session. and will be available for all. Thank you very much.
Thank you, Hani, and thank you, Aziz, in particular for the presentation. We've got our last speaker before we move to the question and answer session. It's Professor Sama Jabor from Lebanon. Sama is a cardiologist and a professor of public health practice at the American University, Beirut. He served as director, the Department of Non-Communicable Diseases and Mental Health at WHO EMRO, the Middle East region, between 2013 and 2015. He's also co-chair of the Lancet, American University Beirut Commission on Syria, and founding chair of the Global Alliance on War, Conflict and Health. He led the Public Health in the Arab World Initiative and co-led the Lancet series, Health in the Arab World, A View from Within, which was published in 2014. He will speak about the impact of COVID-19 on population in areas with armed conflict. Thank you.
Hello, colleagues and friends and comrades. It's a privilege to be with you. As Bridget said, I'll speak about conflict settings. I myself come from Aleppo, Syria, a city that was destroyed essentially between 2012 and 2016 when it was retaken by government forces. And I live in Beirut, which was recently destroyed partially in a terrible blast. That's also really part of the context of conflict and instability in Lebanon, which is also connected with the regional conflict systems that we will speak about. With this, I obviously live the reality of conflict on a daily basis, and this is what I'm going to speak to you about today. I work in the Faculty of Health Sciences, which is a school of public health at AUB. We're deeply involved in issues of public health in our region. Part of that is it's the work in the Lancet AUB Commission on Syria, which is really the first Lancet Commission to be devoted to the issue of conflict and health. You would be surprised that this would be the first such global initiative focusing on conflict and health as part of a multidisciplinary academic work. But conflict really has only in the preceding decade or two has it received the increasing attention from global health. Still inadequate, but we are making some progress there. So what are the issues in conflict settings that we might want to discuss here? I'm going to touch on five topics. The first topic concerns the context. What is it that we are talking about? So there's really a spectrum of context we're talking about. You hear the terms instability, fragility, complex emergency, humanitarian setting, all of that. Really, this is all part of a spectrum. Now, this might seem to many today as affecting regions and countries out there, but in reality, it's actually affecting all of us, whether through refugees flowing all around our world, whether having to pay for the humanitarian operation, or whether through degrading our world, our common world today. This is happening in front of our eyes. Today, in 2019, there were more conflicts than at any time since the end of World War II. Affecting these settings that we are discussing, the spectrum affects about 2 billion people. In 2019, 168 million people almost needed the humanitarian assistance. this is unsustainable. This is unjust, and we should not let this happen. Now, we're not talking about just those contexts, but there's also a lot of side issues that are important from a perspective of justice, from a perspective of equity, from a perspective of prospects. For example, COVID comes in countries that are affected by debt distress. 12 of the countries that have this distress host 40% of the population affected by such settings. Now, as I've just defended and spoke about these settings, I must now try to undo these terms. These are terrible terms to describe realities of people: conflict, instability, fragility. In Syria, it's not a conflict. In Syria, it is a quest for democracy. This is how it started as part of the Arab Spring. In Lebanon, it is not a humanitarian crisis after the blast. It is deeply political mismanagement, deeply troubling political mismanagement related to hegemonic and corrupt practices. In Thailand, where you are now based, many of you, we're speaking about not instability, but we're talking about a youth demanding change. So these terms need to be questioned as we use them. Now, the second issue I'm going to discuss concerns the intersection of COVID-19 and conflict. These are two-way relationships and commonly circular relationships where COVID begets instability, which begets more conflict. In the context of Syria, the information is deeply weaponized. You don't know how bad things are. Patients and health providers are afraid to speak because of possible prosecution and security repercussions. Now, when you bring COVID-19 to a conflict setting, you deeply affect dynamics. And this depends on the context. So there is no summary statement, but that can be made there. In many cases, the conflict continues, or the parties might be just taking a lull to rebuild military powers and continue the assaults. But in everywhere, the state capacity is diminished, and people's and communities' capacities are diminished, and the potential for stability is out. Now, what if we focus more specifically on the health dimensions? So we know the terrible economic tolls that's particularly affecting already marginalized and severely vulnerable population groups, the internally displaced, excluded groups, minoritarian groups, incarcerated people. The health toll, we all know what the health toll of COVID is, but the health toll has a lot more. There's a psychological impact on the communities. There's the foregone healthcare, limited access to services because of competing COVID priorities. Now, in conflict settings, this is already much worse because you're talking about already ravaged health systems, and come COVID-19 to take whatever resources that are available. And in the midst of all of this, the health workers who should be on the front line are at risk. Insecurity Insights released a report a few days ago detailing attacks on health workers, many in conflict settings, in the context of COVID-19. This is on top of the risks they suffer because of lack of access to protective equipment. Now, if you look at the range of actors, there's a lot to be desired, including from international actors. WHO could have done a little bit better, particularly in conflict settings, with regards to addressing the complex issues around needs of competing parties. But the international actors, particularly dominant actors, are the ones who really deserve scrutiny. They've not exerted any influence, any pressures in order to really at least allow some of these conflicts to recede, so that communities and public health actors can work on COVID issues. Now, I'll finish with a set of issues for our collective action. Protecting vulnerable populations is really now a priority. In Lebanon, where I speak, a lot of Syrian refugees have been subjected to abuse on their links to COVID, or their competing for resources. Even in some countries, we have a problem of accessing humanitarian populations needing humanitarian assistance. This is very much the case in Syria, but in many other countries and as well. We need solidarity, but not as a slogan, but rather as a way to operationalize this. And the People's Health Movement is in a very good position to make this happen. I won't have the chance to address the issue of sanctions, but this is really a topic we have to discuss it in a nuanced way, so that we address the issues on the sides of human rights, but also access to essential health needs. Perhaps this is the time for us to rethink about how citizen diplomacy, the type of diplomacy we are doing through talking globally and making this advocacy, but also perhaps pushing in countries where our electoral vote makes sense, pushing for a more formal global health diplomacy. I'll finish with making one point, is that the road to recovery in COVID-19 passes through public health. Public health is the door to recovery. But this path is fought with a lot of problems in conflict settings that really requires our collective actions to address. Thank you very much. I hope I didn't go over time.
Thank you very much. That was very informative. We're going to move over to question and answer session, and Anna Rakar is going to be coordinating the session, moderating the session. Anna is a cultural anthropologist. She's focused on critical and medical anthropology. She works as a program coordinator for Workers' Initiative and Democratization, and is a volunteer at People's Health Movement, currently in the role of regional coordinator for PHM Europe. Thanks, Anna.
Thank you, Bridget. So hi, and welcome everybody to the Q&A session. I would now ask the panelists to please turn on their cameras so we can all have the discussion with and see our faces at the same time. So this is going to take another half an hour, all in all. We're going to open up with a list of specific questions to the specific speakers. And then hopefully we'll have time to do a roundup session with more general comments and thoughts that have arisen during the discussion. So we're just waiting for Aziz and Pat to turn on their cameras, if it's possible at all. Thank you, Aziz. Thanks, Pat. And so we're going to start with a question for Pat. So we are going also to give our panelists a chance to prepare themselves for the questions that we have collected. And basically, Pat, so you were talking and you were presenting quite an impressive case of how the indigenous communities in Australia have been building a strong grassroots response, not only to COVID-19, but also to the structural exclusion from the health system and from social protection systems in Australia. And so we were wondering if this has been recognized by the mainstream public health structures, and if these mainstream public health structures have implemented specific policies that would adequately address the disproportionate impact of COVID-19 on indigenous communities.
Mm. We have quite a good public health system, and certainly in the Aboriginal community health sector, we set up our organisations. Are 70 years old now. In fact, representatives from our First Nations were in Russia, helped draft the Alma Ata Declaration. So we have a long and over many generations contact and experience of delivering quality, comprehensive primary health care. So when we went to Russia, the indigenous world was talking about health, and they all went home and had generations of doctors and nurses and other health professionals. We came home and built our own services instead. We now have doctors and nurses and a whole range of health professionals. So we have the Aboriginal population, we have a long history in the benefits of the primary healthcare movement, if you like. And we've also been in the past, I'm a lapsed member, but quite active in the People's Health Movement. So I'm very happy to be back, Hani. Thank you for inviting me back. So, and we have a functioning health system. So it's been quite difficult. Any gains or achievements that we have in Australia have been through our own activism. Nothing has been given. Nothing has been given. So that's the first. So, but nevertheless, one of our strongest, it's now a political social movement, is the health movement. And it started all those years ago. So our sector is very strong. And we say to the government what's going to work for us and what doesn't. We're always restricted by funding. We're always educating the new generation of health professionals and how to deal with us. But we've gained quite a lot of experience, a lot of strength out of that act of self-determination, I think, and indeed maybe even sovereignty. So we've made the system work for us, despite all of its shortcomings and the refusal of Australia to recognise that this place is our place. It belongs to us. And we're constantly fighting for that kind of recognition. Complex, Australia's a land of paradoxes and ambiguity rather. So it's a hard gig, but we've been able to make a lot of gains by our own activism and the calls for political and social reforms, which is what I wanted to indicate to you, was again another call. We've been doing this since those first boats arrived. It's been a whole generations of activists that have been responsible for change. So yes, I don't know whether it quite answers the question. I think I raved on a bit there, but the health sector, Aboriginal health sector, is quite strong. Look, all those things that's happened here too in Australia, you know, the impact of people being locked down and what have you, but we seem to be a bit more resilient, and we retreated to our communities, and that's kind of, and plus with that history that I've just outlined to you, we know, we understand, we collectively have there's a collective consciousness about disease, and we know that it kills us because that's what's happened to us.
Thank you, Pat. So yeah, I think that it's really impressive what has been happening and what you have been doing all along. And I mean, using the previous experience for building a strong response to COVID-19 is something that I believe many communities around the world would like to look into. And so next we'll move to a question to Carlos. And this is something that has been shared in the Q&A box. So I will read it through. I hope you don't mind. So it says that COVID-19 is an issue deepening vulnerabilities of refugees and migrants amidst the context of generalized and interlocking insecurities. Their inclusion in national policies and strategies will give them some rights, which is a very important first step. But to what extent will it facilitate their access to essential services? And giving increasing inequities that we are witnessing within countries, especially in the West. Are there any examples we can learn from? Carlos, the floor is yours.
Yeah, thanks. Thank you very much. Very, very good question. Thank you very much for that question. Basically, I would say that it's also a very good question because it is important to say that the 2020 has not been so bad. I mean, some positive things we can take from this experience. And then with COVID, this has been also, we have been learning a lot. And this has been the big test. I think this is like the practical test for universal health coverage. For those countries who have been working on UHC, on universal health coverage for a long time, with stronger health systems, with inclusive health systems, basically they have been able to respond much better to this crisis. And this is the important thing to say. Some countries are also now basically understanding this importance of inclusion for migrant populations and other vulnerable groups specifically. And also the importance of knowing that there is basically, there will be no SDGs, there will be no effective response to COVID if all populations are not included. We really can't leave people behind. The response needs to be inclusive and basically moving forward into a more inclusive society. I think that some countries have also recognized that the role that has been played by migrants, which has been very important when most of us were hiding in our apartments, basically because of the virus. All those migrants were in the streets, basically were recognized as essential providers, essential service providers, and they were, most of them, the ones who basically kept the world moving during those lockdowns and those issues. And that also created higher vulnerabilities for those populations. And I think that countries are recognizing that. In terms of best practices, I would say there are many, so this is very positive. We have seen, as an example, Portugal, who is basically, they are temporarily regularizing irregular migrants so that they can be included in the response to COVID. Also, Peru is also providing temporary status so that they can access also the service. We have, I don't know, even Singapore as an example. They have medical facilities, triage clinics for migrant workers, specifically in areas where they live, in the dormitories, in the places where they live. I don't know, also in terms of...
You're coming out soon?
Yes, also in terms of protection schemes, I would say that Malaysia, as an example, reduced the fee for migrant workers so that they can keep their status, etc. A lot of also capacity building in Argentina, in Chile, Peru. I don't know, many good news for universal health coverage. Thanks.
Thank you. And so we can now go to Aziz, who has been mentioning also the impacts of the now very present and quite popular austerity and neoliberal policies, which have been impacting and shaping health systems all around the world. But we do know that the Middle East and North Africa region has been specific, and it has been specifically impacted by this. So Aziz, if you could maybe elaborate a bit upon how have these policies led to certain populations being excluded from access to care. And in the case of COVID-19, if this has intersected with some breaches of human rights, which have been documented in the region and in Morocco specifically. So, of course, if you would like to elaborate on what the Right to Health movement has been saying and doing on this, it would be most welcome also.
Thank you. أظن لأن المنطقة شمال إفريقيا والشرق الأوسط عرفت تدهورا كثيرا أو ارتباطا كبيرا بالأنظمة النيوليبرالية، خاصة منذ سنة 2003 بعد حرب العراق وحرب لبنان. فالمنطقة عرفت هجوما كبيرا من طرف القوى النيوليبرالية في المنطقة. فيما يتعلق بآثار السياسات الليبرالية على المنطقة، فإحدى أولى النقط التي ظهرت بقوة هي أن كل ما كان يتحدث عنه القطاع الخاص ودور القطاع الخاص والذهاب في اتجاه خصخصة القطاع، ظهر مع كوفيد على أن هذا القطاع اختفى بشكل كلي، وأن القطاع العام هو الوحيد الذي حاول أو يحاول أن يتحمل عبء كل المرض. بمعنى أن كل الرهانات على القطاع الخاص الكوفيد 19 أظهر على أنها غير مجدية ولم تستطيع أن تواجه. هذا من جهة. من جهة أخرى، اعتماد دول المنطقة خاصة دول الشرق الأوسط على البترول كنقطة قوة للنهوض الاقتصادي أبانت، وخاصة بعد انخفاض الصادرات بحوالي 41%، أبان هشاشة هذه الدول. بالرغم وكذلك أن الصورة التي كانت تعطى على دول المنطقة أنها دول متقدمة وأنها قادرة أن تحقق الكثير من الحقوق، فمع كوفيد ظهر أنها دول عاجزة. فحتى الإحصائيات التي تعطى عن السعودية والكويت وقطر، فهم يقومون فقط باحتساب المواطنين السعوديين أو الكويتيين أو القطريين، ولا يهتمون إلى العمالة الآتية من آسيا. إذن كل هذه المعطيات تعطينا على الأقل أن كوفيد أعطانا نحن كمناضلين أو توجه سياسي معين أننا كنا على حق، وأن لا يمكن أن نغير الوضع إلا بالخروج من إيجيمونيا نيوليبرالية من خلال طرح بدائلنا نحن. فنحن من كان يدافع عن القطاع العام، نحن من كان ضد الخوصصة، دور المجتمع المدني كان قوي من أجل إيقاف هذه السياسات، نحن من كان يطالبون بدور قوي للأمم المتحدة. ففيروس كوفيد أظهر أنه لا يعترف بكل الحدود الموقوعة التي وضعت أو التي الموضوعة بين الدول، بل ذهب بشكل ترانسفيرسال أو بشكل عرضاني لكل الدول، ولم يكن هناك أي دولة سواء متقدمة أو متوسطة في منأى عنه. إذن يجب أن نطور ويجب أن نخرج بدائلنا للعالم ونقول أن ما كنا نتحدث عنه بشكل محتشم هي الحقيقة، وأن لا بديل على القطاع العام، لا بديل على الدول، لا بديل على منظومة حقوقية تضمن للإنسان حقوقه كإنسان، لأن ضمان حقوق الإنسان هي ضمان لكرامته. إذن لا بديل على دور كبير للأمم المتحدة من خلال مؤسساتها، خاصة مجلس حقوق الإنسان وكذلك منظمة الصحة العالمية. لا بديل على القطاع العام كآلية للرفع، وخاصة فيما يتعلق بالحماية الاجتماعية. كوفيد أظهر على الهشاشة الموجودة داخل المجتمع من خلال تفشي الفقر، لأن ليست هناك حماية اجتماعية شاملة. ولما نتحدث عن الحماية الاجتماعية الشاملة ليس بمنظور الإفمي أو البنك الدولي، ولكن حماية شاملة تتحمل فيها الدول مسؤوليتها، ولا تتحول الدول فقط إلى مراقبة أو راعية أو ميسرة للوصول إلى الحماية الاجتماعية.
Thank you, Aziz. Hani, could we trouble you just to give us a quick overview?
Yes, very quick. Aziz mentioned that the adoption of neoliberalism in the region, in the Arab region and Middle East, started to be much bigger in 2003 after Iraq war. And he also indicated the impact, talking about the role of all the talks about the role of private sector have been exposed to great extent, and during the COVID-19 pandemic, only public sector is dealing with it, and the private sector is became more like a burden, is not participating really in combating the COVID-19. He also talked about the fragility of the economy in oil-producing countries, depending to great extent on oil, and they tried to increase social protection for their citizens, but not for the foreign workers. And in some countries, these are quite dominating in numbers. So he summarized that this proven to great extent what we've been talking about as social movements. There is no replacement for the public sector, and we need to work together to strengthen the public sector. We need a bigger role of governments, and the governments should not convert to be just coordinating the efforts from of private sector. Also, he insisted on a bigger role of UN organizations and international community as member state organizations. I hope I made justice to what he said.
Thank you, Hamid. And I think that the next question to Samir is going to be quite related to what Aziz has just been saying. And it actually relates to a more to a broader picture. And so, Samir, could you elaborate a bit on the forces that are dominating the scene in the Middle East right now, and who is currently benefiting from the situation there, especially when it comes to the international community silence on the situation in Syria, in Lebanon, in Libya, in Yemen, but also in Egypt and the other countries?
Since the Arab Spring, it has become quite clear that this region is now in a state of exception, particularly with the backing of in Egypt of allowing the military to take over as the custodian of the state, and then to enact its coup in 2013, and then institute a police state with the Obama administration not standing up to its word of a red line around use of chemical weapons in Syria. With the turning the back on the pro-democracy movements in the Gulf, in Bahrain and elsewhere, it has become clear that this region sits at the intersection of monumental forces whereby the chances for change are closed. So on the one hand, you have the state tyranny that has led us to unprecedented decline. Number two, you have the intersection of geopolitical interests, including the issue of oil, but not limited to the issue of oil, competing regional and international powers who just think that this region is really up for grabs. And the third is that you have really weakened civil society and no institutions because of lack of freedoms and democracy. However you look right now in the region, you don't have an opening. Remarkably, Lebanon which many years ago used to be the model of instability, up until a few years ago, was said to be the more stable of all these surrounding countries. Now Lebanon is gone too. So we are not allowed essentially to move forward in this region. And this is not just a global powers. This is also regional and local powers that are enacting agendas in Lebanon. Hezbollah is now dominating the decision-making regarding the state. So state within state, the French initiative to save the financial ruin was essentially blocked because of competition over power positions. So this region is in a very difficult place. We, however, are not recognized as needing to be saved. So some years ago, a lot of development efforts rightly was going to sub-Saharan Africa, recognizing that you've got to do something about the terrible situation there. What we have in our region is that we have a terrible situation, but no recognition of how terrible it is, and no as the colleague who raised the question, no serious questioning of the global progressive voices of why things are they are and what can we do to save this region. I'm sorry that my answer is so gloomy, but the situation is how I've described it now.
So thank you for the gloomy answer. I think gloomy answers are usually useful for reflection. And so we have another 10 minutes for our discussion around. And so I thought that maybe we could round up with a more general question for all the speakers, but also Bridget, if she would like to come in on this. And so I think many of you mentioned already that you found yourselves in different roles. Some of you work for international organizations, some of you are academics, some of you are part of people's health movements. And well, most of you are a lot of these things at the same time. So it would be interesting to hear what you see as the particular role that social movements can do in the situation of a COVID-19 pandemic and all the political implications of it, but also what is it that international organizations would like to do, and what are some of the obstacles that they are facing. And yes, so the floor is open for all of you. I don't know if maybe you want to start in the same order. So Pat, if you have anything to add.
No, I don't think so. I'll just maybe at the end, Anna, if there needs something to be said.
Okay, sure. So Carlos, maybe we move on to you then.
Yes, I would insist in terms of visibility. Basically, migrant populations, vulnerable populations, they need to be seen so that they can be included. And this is the big gap that we see in some countries, where there is no even a clear definition of who is a migrant. So you can say, sometimes people say, okay, in this country we have great services for migrants, but when they define migrant, they are including only the migrant worker. But there are many other migrants that are not basically who are in an irregular condition, who are not included, and basically they are left behind. So I think that this is very important. It's in terms of visibility. The thing that we need to really highlight so they can be included. And the only way to do this is through a good networking. And good networking includes civil society, includes UN agencies, includes all of us, academics, all of us working there. It should be basically, there should be a network to work within. And the most important thing that I think I said that during the presentation is to adapt our responses to the needs of the population, to the language, to the cultural perspectives, to adapt. And the only way to do that is by creating capacities, but also making them part of the team. So the idea is basically to work everything with the migrant populations and to define the best next steps with them. So it's more about participation, inclusion and participation. We'll leave it there.
Okay, thank you. And so moving on then to Aziz and then to Samir. I would just like to know the time. We have 4 minutes left for this. So if we could keep it quite short, but also, yeah, you know how it goes. Usually say everything, but in 2 minutes.
أذهب إلى نقطتين أساسيتين. فالنقطة الأولى هي أن كوفيد 19 أظهر على أن العالم بأسره لا يمكن فصل دولة على أخرى، وأن حتى الدول التي كانت تظن أنها دولة متقدمة من الناحية الصحية مثل فرنسا وإيطاليا بان كيف انهارت منظومتها الصحية. هذا من جهة. من جهة ثانية وهي إعطاء أهمية لكثير من الحقوق التي لم نشتغل عليها كمجتمع مدني قوي، خاصة الحق في التنمية. جائحة كورونا أظهرت على أن نظرية التطور الاقتصادي واحتساب الدخل الفردي أو الدخل السنوي كمؤشر ضعيف جدا، بل يجب أن نعيد ونعطي قوة للحق في تنمية الشعوب حتى نستطيع أن نتقاسم ثروات شعوب، وهي المدخل للقضاء على هذا النوع من الجائحة. ولا يجب اعتبار جائحة كورونا هي آخر شيء، فممكن أن تأتي جوائح أو جائحات أكثر خطورة من كورونا إذا لم نشتغل جميعا من خلال خلق شبكات قوية للمجتمع المدني لتغيير ميزان القوى. شكرا.
Just to summarize what Aziz said, he said that one of the big lessons of COVID-19 pandemic is we learned that the world should be working together. We cannot separate countries from each other. The impact is universal. And also those countries that they have been perceived as strong countries with good systems like France and Italy have been impacted so badly. Also, he talked about the indices. Economic indices are not enough to measure our advancement, and he's calling to including the right to development and find other indices that can act better for human beings. And he talks about a bigger role of social movements and resistance to for better life, for better indices. For thank you.
Thank you, Aziz and Hani. And so the final conclusion for Samir, and then we move on to Bridget and her thoughts.
Anna, it's an amazing question. It's a very important question. And I wish we had a full hour to discuss this, because COVID-19 is diagnostic. It provides you a diagnostic tool of societies, of economies, of health systems, but of yourself. And you raised the question, what's the role of social movements? And I think COVID also exposed not just the fragility of social and economic systems, it's really showed that we need to go back to the drawing board and rethink our global community. We rethink our tools. We're not as strong as we thought we are in the face of Trump and climate change, environmental degradation, conflicts, and all of that. So there's a lot of work to be done. PHM provides a beacon of hope because it brings together all of these progressive voices, and this is an opportunity. COVID is an opportunity for us to right now say we are at a crossroads, and we have got to save ourselves, save our humanity, and save our planet. Over.
Thank you. So thank you to all the panelists. I will now go back to Bridget, who is going to offer some conclusions and thoughts on this. And thank you everybody for the great questions.
Yeah, no, I'll echo Anna's thanks. It's been a very rich presentations given, and it's not that easy to do a concise summary of it, but I'm going to try and highlight some of the problems that I heard highlighted through the discussions, as well as some of what I've heard, some of the way forwards, and a couple of examples from the presentations. So I think what nearly everybody highlighted was some of the systemic and historical inequities that exist within countries, that political actions or non-political actions have impacted on how COVID has been dealt with and how it has affected particularly some of the vulnerable populations we've spoken about. Exclusion, people who are excluded from health systems because of who they are. Then the health systems crisis. The pandemic has mainly been dealt with by the public sector, as Aziz mentioned. It has highlighted the weaknesses within the private health sector, but it's also highlighted the need for us to build strong public health systems. The suspension of protection, we heard how migrants have the problems driving migration continue, yet there is a blockage that has happened and not allowed people to receive the protection that they should be having. Fears and stigma surrounding COVID, but also then affecting particular populations more. Some of the social inequities where somebody is already in a vulnerable situation and poverty has increased, hunger has increased. Compromising of people's income security, education, food insecurities happened. And then there were the interesting one around terminology and how we describe things. And very often we project inaccurate reflection by how we use terminology. So I think it's highlighted very strongly the fragility of our health systems and the fragility of our social systems. Summer said right now spoke right now at the end of how we need to rethink how we do things. So moving on to the way forward, I think that it really has given us a reflection of a world that has got a lot wrong, and that it gives us a perfect opportunity to start mobilizing around a way forward. In terms of some of the solutions that got put forward by the panelists, we heard, sorry, before moving to that, I just wanted to highlight a couple of the points that had been raised. Pat, it was very interesting to hear about how community-controlled health centers have ultimately, as well as the understanding of Indigenous people within Australia around health and consciousness of disease, has actually meant that there's a lesser impact on the Indigenous population of Australia. But Pat also spoke of activism, how children would stand on the side of the road and disinvite people from visiting the communities. So what some countries struggled to contain through a top-down process, we heard within Australia was coming from a bottom-up process. Carlos, it was a really interesting presentation, and hearing particularly around, the increased vulnerabilities of migrants. I think you repeated when you were summarizing, or in the question and answer as well, that the most vulnerable, because of often being in a place, either a cleaner or in a public position where you're exposed, are often those who are also left out of a health system and out of a solution. Aziz spoke about the increasing inequities, which I think we've all seen in our countries, and we see it globally as well as the role of the public sector in dealing with this. Sama spoke about the terminology, and I think it's something we have to bear in mind in moving forward. The one example was instability versus political mismanagement. It avoids, if we say instability, it points a finger at those vulnerable rather than the political mismanagement, which actually places the need for change directly where it should be. So in terms of way forward, and I'll be quite quick in terms of summarizing, some of the things that have been repeated by a number of speakers: solidarity, collective actions, as well as community actions. But then we also need some form of action that takes place globally and direction given globally. The phrase, if somebody is left behind, no one will move forward. And I think right at the beginning of COVID, there were fears in many populations about how this would be spread. But I think that it's really, really demonstrated how COVID has no known boundaries, but that we actually have to bring along everybody with us. The strength of the public sector, I think PHM and People's Health Movement has for a long time pushed for strengthening of public health systems. And I think COVID has demonstrated the importance of this. visibility to be increased, that those who are more vulnerable need to be made more visible. So it's not just someone speaking on behalf of them, but also people being able to and empowered to speak on behalf of themselves. The importance of networking, and that's across different sectors, from civil society to academia to social movements to the public sector. And that really the point that I want to end on is to rethink how we do things, that we need collectively, globally, within our countries, within our communities, start identifying what needs to change so that we aren't in a, COVID is by no means finished. We've got a long way to go before it is over. And we need to find ways within this crisis to be able to mobilize civil society, mobilize community action, mobilize global actions, particularly where they're going to impact on local. And I think that are the main points that I've pulled out from here. But I want to thank the panelists as well as to Hani for putting a lot of effort into pulling this session together. And of course, the Prince Mahidol Award Conference and the Secretariat in particular, who's given us this opportunity and provided all of the background support to getting this session going and getting the links up and practicing. And thank you very much for all of that. I think we've got information about future session, the next session. So on the 28th of October, and it starts 1 hour later than this session, there's a session which would be a follow-up to this one, which is on resistance, opportunities and threats during the COVID pandemic. So please do diarize and try and make an effort to come. There's a lot of other, if you go to the Prince Mahidol Award Conference website, there's a number of interesting webinars that will be taking place over the next while. Thank you everyone for your participation.